So today basically we're going to talk about things that you know already. So we're going to talk about the journey of the sperm from the testicle or testicles all the way to the outside wall. Okay? So let's start with the testicles. I'm not going to talk about the histology. Dr. Zafar or Dr. Oni will talk about it. But generally speaking, the testicle is surrounded by a fibrous capsule, and we call that tunica albuginea. Albuginea means what? White, because it looks white. And from there, it's going to send the fibrous septa to divide each testicle into about 250 lobules. Okay? So these fibrous septa will divide the testicle into close to 200, 250 lobules. In each lobule, you're going to have 1 to 4 seminiferous tubules. What's in seminiferous tubules? We have, what do we have in there? We have the cells that will produce the sperm, right? So from the seminiferous tubules, so we'll have sometimes close to 1,000 seminiferous tubules, right? All of them will drain into this area in the middle. It's a network of channels that will receive the production from all seminiferous tubules. It's called the rete testis. Okay, in the mediastinum, in the middle of the testis. So all these seminiferous tubules will be reduced into a central area, a network of ducts or channels called rete testis. From there, we will have 25 ducts that will take the sperm from rete testis. We call them the vasa efferentia or efferent ductules. So we'll have 25 of those. Now all these 25 eventually will lead to a single duct. This single duct, we're going to coil it and bring it together by connective tissue. And we're going to call it as epididymis. So actually, from seminiferous tubules to rete testis to efferent ductules, 25 of them, all of them will lead to a single duct. That single duct is the epididymis. Epididymis is going to look something like that. So we're going to reduce the 2 meters into about 6 centimeters. Right? So epididymis is going to be placed on the posterior superior aspect of the testis, and it will have a head, a body, and tail. So see how it is coiled and brought together by connective tissue. Now it will be sitting on the posterior superior surface of the testicle. The space between the two is called the sinus epididymis, and it is filled by this balloon-like structure. You know, this is like a deflated balloon hugging or covering the surface of the testicle. What is that? It's a 2-layer fold of peritoneum. What do we call this? We call that tunica vaginalis. What is the origin, where it came from? Yeah, processus vaginalis. So when the testicles were in the abdomen, sitting on the posterior abdominal wall, right? And then they will descend into the scrotum. So as they descend, they will bring a 2-layer fold of peritoneum with them. It's called processus vaginalis. Okay, and the processus vaginalis will descend through the inguinal canal, right? Will be one of the contents of the spermatic cord. You know, it will descend through the inguinal canal to reach the scrotum, and later, within a few months, the rest of the processus vaginalis will disappear, and what remains is the tunica vaginalis, which is this, the balloon-like structure applied to the surface of the testicle. So between the epididymis and the surface of the testicle we have the tunica vaginalis. So as you can see, coil, less coil, and then we'll have the tail, and epididymis will continue up as vas deferens. Okay? So from seminiferous tubules, retail testis, efferent ductules, 25 of them, single duct, it's called epididymis, then we bring it together to make it short. We cannot afford to keep it like 2 meters in length, and that is epididymis. From epididymis, the tail will continue as vas deferens. Now vas deferens, that is the epididymis, continue as vas deferens. Vas deferens will be one of the contents of the spermatic cord. Have you ever heard of a spermatic cord? What does it mean? It's a collection of structures that will enter or leave the scrotum and the testicles, like testicular artery, veins that drain the testicles, lymphatics, nerves, and all of these will be wrapped by 3 layers of fascia. We call that spermatic fascia. Where do they come from? Again, as these structures pass down from the abdomen to the scrotum, they will bring them with them layers from the anterior abdominal wall. So there will be external spermatic fascia coming from the external oblique, cremastric fascia coming from the internal oblique, internal spermatic fascia coming from the transversus abdominis. So my point is, all these layers of our anterior abdominal wall will become like fascia covering these contents. These contents, collectively, we call them spermatic cord. This spermatic cord will pass through the inguinal canal. Okay? So one of the contents, as you see here, this is the spermatic cord passing through the inguinal canal from superficial to deep. And one of the contents in red, you can see the testicular artery. In blue, these are the testicular veins and piniform plexus. And this is the vas deferens. So vas deferens will go within the contents of the spermatic cord through the inguinal canal, and from there it will leave the inguinal canal and will run on the lateral pelvic wall. So leave the inguinal canal on the lateral pelvic wall so that it goes behind this structure. What is that?
Bladder.
What do we have immediately behind the symphysis pubis?
Bladder.
The bladder. So it will run behind the bladder, and you can see it is crossed by the ureter, right? It is crossed by the ureter. So this is the bladder, this is the vas deferens, crossed by the ureter. Now the vas deferens, before it reaches its final destination, it will dilate, becomes the ampulla of vas deferens. Why? Because you have millions of sperms, and then you have a narrow exit, narrow ending. So they need to wait and take turns before they exit. Now behind the bladder, what else do we have? We have this tubular structure, granular structure, that is the seminal vesicle. Now seminal vesicle is about 2 inches in length. What do they do? Why do we need seminal vesicles? They contribute to the semen. They provide whatever the sperms need to remain alive for nourishment, okay? Now the vas deferens and the seminal vesicles will unite. They will form a single duct. This single duct is called the ejaculatory duct. This ejaculatory duct from the right and the ejaculatory duct from the left, they will open in the posterior superior surface of this apple-like structure, which is the prostate. Okay? So the 2 ejaculatory ducts will open. This is the prostate. In blue is the prostatic urethra going through the prostatic cavity, and they open here, and this structure that we call seminal colliculus, we'll explain it later on. But they open inside the prostatic urethra. These are the 2 openings of the ejaculatory ducts. Now blood supply for the testicles, arterial supply will come from the abdominal aorta. This is how important it is. Okay? So we have two gonadal arteries. Gonadal refers either testicular or ovarian, right? So they will come from the abdominal aorta, just below the origin of the two renal arteries, right? At the level of L2. So you have the testicular arteries, and then they become among the contents of the spermatic cord, reaching to the testicles. Also, we have another artery, which is artery to the vas deferens coming from internal ear. What about veins? Testicles are drained by a plexus of veins, not a single vein, plexus. They start as multiple veins, 12, 14, 16 veins, called pampiniform plexus of veins. Okay, and then as they ascend up, they will be reduced from 12 to 10, 8, 6, 4, and then eventually you will have a single gonadal vein or testicular vein. The one on the right will drain into inferior vena cava. The one on the left will drain into the left renal vein. Okay? They say that's why you have, varicose veins more in the left testicles, because crossing the left renal vein is actually the superior mesenteric artery, which is a really, really heavy artery. So it is causing some congestion. This is one of the theories. Another point, as you can see in the spermatic cord here, there is a single artery, but there is a plexus of veins surrounding the artery. Do you know why?
For temperature,
This question is for atheists who don't believe in God. Why do we have a plexus of veins surrounding the artery? What can impede spermatogenesis? What is not good for spermatogenesis? Why we ask you not to wear tight jeans? Huh? Heat. Temperature. High temperature is not good for spermatogenesis. So, the testicular artery is coming from the abdominal aorta. So, good flow, really hot blood going to the testicles. So, to absorb the heat from the testicular artery, these plexus of veins will do that and will reduce the temperature of the blood going into the testicle. Now again, if you ever cannot remember the lymphatic drainage, where does it go, which lymph nodes, you always follow the arteries. Most of the cases, you always follow the artery. So testicular artery is a branch of the abdominal aorta. So lymphatic drainage or lymph from the testicles will go into para-aortic lymph nodes along the abdominal aorta. Any questions so far? Fine. Now, we're going to link all of this to this organ here, which is the prostate. You took it in the renal block, right? So let's just refresh our memories. What do we know about the prostate? Now, number one thing that you need to know, that the wall of the bladder is continuous with the wall of the prostate, right? Can you separate the prostate from the bladder?
No.
Are they two separate organs? Can you separate them? No, why? Why we cannot separate prostate from the bladder? Because they share a common cavity. So urine from the bladder will go through the prostate to reach the outside, prostatic urethra. And semen will go into the prostate to reach the outside. Okay? So the wall of the smooth muscle wall of the bladder will continue with that of the prostate. Now, prostate is conical in shape or pyramidal in shape. It has a base and has an apex. The base is basically where the neck of the bladder is sitting on. What about the apex here? The apex is sitting on what we call the urogenital diaphragm, and I will have a full lecture on is part of the perineum, and I'll tell you what a urogenital diaphragm. But briefly, now, all the structures in the pelvis are not just standing like this, right? Otherwise, they will be falling whenever you will be walking, when you're running, when you're standing, right? They are supported by pelvic floor or pelvic diaphragm. Basically, we have two major muscles here, levator ani and coccygeus. They form what we call the pelvic diaphragm. And in that pelvic diaphragm, which we have all the organs in the pelvis sitting on it. But we have to have openings in that pelvic diaphragm. Openings for what? What goes from the pelvis into the outside? Urethra, vagina in females, and anal canal. So that's why the pelvic diaphragm has openings for the anal canal and for the urethra in males, and urethra and vagina in females. So that is for the anal canal, and this area here, this defect, is for the passage of the urethra and or the vagina. Now this area here between the pubic arch is not open like this. It is actually covered by a musculofacial membrane that is called the urogenital diaphragm. Why do I need a urogenital diaphragm? This area here is covered by a musculofacial membrane, two fascia, and we have muscles in between. Why? Because I need to provide attachment for the external genitalia. You can see that the urogenital diaphragm here in females, you have that is the clitoris, the external genitalia of females, and similarly this is the urogenital diaphragm providing attachment for the roots of the penis. Okay? So why we're talking about the urogenital diaphragm? Because we said that the prostate, the base is surrounding the neck of the bladder, the apex is sitting on the urogenital diaphragm. Okay? Now, this urogenital diaphragm is this. So that is the base, this is the apex, that is the urogenital diaphragm. Now the prostate has two capsules. One true capsule, fibrous capsule, the usual capsule, and one on the outside that is composed or formed by adipose connective tissue, that is a false capsule. Now between the two capsules we have the veins, a plexus of veins that will drain the prostate. Now, again, remember that the wall of the bladder, this is the bladder, right? This is the urethral opening. The wall of the bladder is continuous with that of the prostate. Why? Because they share a common cavity. So this is urine will come from here, go through the prostate, prostatic urethra, and then part of the urethra is through the urogenital diaphragm that we just spoke about. It is called the membranous urethra, and then we have the penile urethra. So what are the relations to the prostatic gland? Anteriorly, what is this? Anterior to the prostate, you have the symphysis pubis. Separating the two is basically a space filled with fat. That space is called cave of Retzius. Space filled with fat to minimize friction or prevent friction. What about posteriorly? What do we have posterior to the prostate? What is this going through the prostate actually? That is the ejaculatory duct. What is posterior to the prostate? What is that? The rectum. So there is nothing separating between the prostate and the rectum except a thin fascia that is called Denham-Valier's fascia. Okay? That is why the best way to examine a prostate is digital rectal examination through the rectum. You know, you can palpate the prostate and feel whether it is enlarged, there is an abnormal growth, and so on. So that is anterior, that is posterior. What do you think is lateral to the prostate on each side? We said all these pelvic organs are sitting on what? On the pelvic floor, right? So on each side of the prostate you will have the pelvic floor, which is basically like that. This is the prostate sitting on the urogenital diaphragm, but on each side we have the pelvic floor, right? In the middle you have that defect covered by urogenital diaphragm, okay? So laterally you will have the levator A9. Now when it comes to divisions, anatomists, they say the prostate has 5 lobes, right? When you go into year 3, the pathologists, they would say, forget about the lobes, we care about regions or zones. So they're going to say we have a central zone, we have transitional zone, we have peripheral, and so on. Okay, for anatomy, from anatomical point of view, the 5 lobes of the prostate are as follows. Now, anterior to the urethra, that is the anterior lobe. And this is a glandular lobe, or non-glandular lobe. Okay? It has no glands. It's all fibromuscular. Now, between the urethra and the ejaculatory duct, that is the middle or the median lobe. That is highly glandular. So guess which lobe will be mostly responsible for enlargement, benign prostatic hyperplasia? The middle lobe. So what will be the most obvious or the first sign of prostatic enlargement? Patient will come to you with difficulty urinating. Why? Because if this enlarged, it's going to close the urethral opening. Now, just below the ejaculatory duct and behind the urethra is the posterior lobe. And then we'll have 2 lateral lobes, one this side, one on the other side. So the lateral lobes will look like this. This is a lateral lobe, that's a lateral lobe. This is an enlarged median or middle lobe, and then here we have the anterior lobe, okay? Now, when it comes to pathology or pathologists, they're going to tell you that we have central zone, which is basically corresponds to the median or the middle lobe. We have transitional zone, which is basically corresponds to the anterior lobe. And we have the peripheral, which corresponds to the posterior lobe. So peripheral, posterior, transitional will be the anterior, and the central is the glandular part, which is the median or middle lobe. Of course, the lateral lobes will have elements of all 3. Now, did we miss anything? No. Okay. Now, this is the bladder. That is the prostate. This is the prostatic urethra. Now, at the neck of the bladder, we have what we call the internal urethral sphincter, right? Which, voluntary or involuntary? Involuntary, right? This you have no control over it. Well, so since we have an internal urethral sphincter, we should have. Where is the external? External is actually in the, remember the urogenital diaphragm? It is in the urogenital diaphragm. Okay, so this is the voluntary sphincter, the external urethral sphincter. So we have 3 parts of the urethra: prostatic, which is the widest and the most dilatable. And then we have a very short portion, which is the membranous. It's about only 1 centimeter. Okay? And then we have telling the external urethral sphincter. And also in males, we have what we call the Cooper's gland. they secrete mucus to lubricate the area they open into the bulk of the penis. Okay, so prostatic, membranous, and benign. Now let's open the prostate, and this is the stuff that you know. If you open the prostate, this in blue is the prostatic urethra. Within the prostatic urethra there is an elevation, there is a ridge. It is called the prostatic crest. Now the summit, the top of that crest is called the seminal colliculus or colliculus seminalis. So if this is the crest, the top of the crest is called the seminal colliculus. What do we see on the top of the crest, the seminal colliculus? We have three openings. One is called the utricle. It's a dead end. It's just their little opening. It comes from paramesonephric duct. Functions are unknown, but many believe they will help during ejaculation. They will help, create a negative pressure or, withdrawing sperms from these openings, the ejaculatory ducts opening. Okay? So, urethral crest, the top is the seminal colliculus. On the seminal colliculus, we'll have the utricle, and then we have the two openings of the ejaculatory ducts. Now, on each side of the crest, we have the openings of the glands of the prostate, that is called the prostatic sinus or sinuses. Okay? Now again, this is the bladder, this is the trigone, urethric opening, this is the internal sphincter, that is the prostate, that is the urogenital diaphragm, this is the external sphincter, these are the the Cowper's glands, they open into the pulp of the penis. This is the urethral crest, that is the utricle. These are the two openings of the ejaculatory ducts. Now, when it comes to blood supply, it's easy. All the organs in the pelvis are supplied by internal iliac. You have abdominal aorta, two common iliac. Each common iliac will divide into external and internal. External becomes femoral. Internal goes to the pelvis, divides into anterior and posterior. So for the prostate, the two branches of the internal iliac that will supply the prostate are the inferior vesicle and the middle rectum. What about the veins? Remember we said the prostate has two capsules, one true capsule, one adipose tissue capsule, and in between we have plexus of veins draining the prostate. Now this prostatic plexus also received a major vein from the penis. It's called the deep dorsal vein of the penis. So sometimes the people with prostatic enlargement, they have poor drainage from the penis. They will have pathological erection. Erection is about filling the cavities with blood, and to get rid of that you have to evacuate blood. If the main vein of the penis is obstructed, the drainage, so they might have pathological erection. Anyways, but the prostatic plexus of veins communicates with that of the bladder and with that of the vertebra. Right? And this is important clinically. Why is this important clinically? Yeah, because cancer metastasizes through three routes, right? Either direct invasion, or through blood, or through lymphatic. Now, in case of the prostate, lymphatics of the prostate, they don't play a role in metastasis of the cancer of the prostate. Why is this? Because lymphatics, they don't drain the glandular tissue. They drain the capsule. And the cancers, they occur in the glandular tissue. Okay? So there are these are two important clinical points, is that prostatic plexus communicates with that of the bladder and that with the vertebra, so cancer can metastasize to the vertebral column, to the bladder, and so on. And also lymphatics of the prostate, they don't carry cancer cells because they don't drain the glandular tissue. When it comes to the nerve supply to the viscera, it comes from autonomic nervous system. So it's either sympathetic or parasympathetic. I mean, not either, it's sympathetic and parasympathetic. So sympathetic will help in the smooth muscle contraction, in this case, during ejaculation, and while parasympathetic will help in the acinine production, basically the glandular functions, okay, produce the prostatic fluid. So as promised, any questions?